Welcome. Good morning, good evening, good afternoon, good night for those who are in Asia to this exciting webinar on the RayOne Galaxy. We are going to present and introduce you to new clinical results and some sort of real-world outcomes. I am your moderator for tonight. My name is Francesco Carones, and we're going to explore the latest clinical results with the Rayner RayOne Galaxy, the first spiral IOL designed with AI. We have a very nice agenda. We have a great faculty. I'm going to speak a little bit about it. Mr. Raphael Neuhann from Germany, Dr. Başak Bostancı from Turkey, and Mr. Allon Barsam from England. We are going to focus on our own experiences as well as from the most impactful results from a multi-center study. But I just want to introduce you the topic, showing a few slides, actually one, on the clinical value in terms of benefits and side effects of IOLs. And you see here in this slide what I can represent IOLs being able to provide spectacle independence, but at the cost of dysphotopsia, especially at night. And we know that in this ratio, we have diffractive in increased range of focus IOLs who are very high in terms of night dysphotopsia that they may induce, as well as we have diffractive full range of focus, able to provide more spectacle independence, but still at the cost of night dysphotopsia. Recently, lenses with a refractive pattern in the increased range of focus area have been introduced, but they do not provide a full range of vision. And so here is exactly where I think the Galaxy may fit very well, being the only refractive full range of focus IOL, being able to provide high levels of spectacle independence at a very low cost or compromise as regards dysphotopsia. Let's start immediately hearing from Raphael Neuhann from Germany about his overview and preclinical study.
Looking forward to talk to you about a small overview about the Galaxy Spiral IOL, how it works, how it was developed, and showing you some data from the first preclinical study that was done by colleagues in Austria. And when we talk about presbyopia correcting lenses, we also want to mimic crystalline lens accommodation. So the basic principle, I think you all know, that when light travels from a distant source into the human eye, we need lower, not a that high refraction inside the eye to focus the light on the retina, so that will result in a lens with a flat curvature. However, when we move an object closer to the eye and the light will travel from a near source, we need to have a higher refraction in the lens to still focus the light onto the retina. So that will result in a steep curvature of the intraocular lens. Combining these two or even more features to provide a great range of vision is the ongoing struggle with all lenses we know. So how was it done in the Galaxy IOL? Here you can see the Galaxy surface construction. It has a far, intermediate, and near optical elements. And illustrated on the right side of your image, you can see it was how the different areas are incorporated into the optic using continuous spirals to provide a smooth surface and a smooth continuous vision. So to get there, Rayner was using a proprietary AI engine that created a unique optical spiral tuned for optimal patient outcomes. The spiral tracks allow continuous variance of power, focusing light at every position along the defocus curve. This results in a precise control of the optical power from far to near focus, producing a smooth and continuous full range of vision. And when we look at the smooth and continuous changing surface, This will allow less abrupt transitions, like in diffractive IOLs that we know, and that decreases dysphotopsia and light loss. So when we look at the preclinical study that was done in Austria in collaboration with Dr. Bresner from the Austrian Center for Medical Innovation and Technology and Professor Michael Allon from the Academic Teaching Hospital in St. John, they were using the RALPH device. You maybe all know that or heard about it or saw it already at meetings. This device gives a real visual impression of IOL performance without implantation of these lenses. There were 30 healthy subjects between 18 and 40 years, and the IOLs were inserted into the RALPH device for intrapersonal comparison. IOLs used were enhanced monofocal IOLs, trifocal IOLs, diffractive trifocal IOLs, and the Galaxy Spiral IOL. These were all monocular tests, and the test took about 45 minutes, and it's a personal preference test. So the first thing they looked at was mean contrast sensitivity at distance, intermediate, and near. And here you can see there's the comparison between the Galaxy IOL and a trifocal diffractive IOL. And you can see the Galaxy Spiral IOL demonstrated better contrast sensitivity compared to a diffractive trifocal IOL, especially at near. The next focus one was on, and I think that is what everybody is really interested about, the monocular halo test at a distance of 4 meters. And here you can see the three IOLs, the Galaxy Spiral IOL, the trifocal diffractive IOL, and the enhanced monofocal IOL. And as you can see, the halo patterns between the Galaxy and the enhanced monofocal were very similar. So it's very close, the Galaxy halo is very close to that of an enhanced monofocal, but significantly better than in the trifocal diffractive lens. So this is, I think, very astonishing and very promising for the future, and this is something what we all wish for. And at last, they asked the patients for their subjective, or the subjects for their subjective lens preference. They were showing them an image, as you can see see here with the balloons for distance vision, an image of a Google Maps image for intermediate, and a phone chat for near vision, and asked them for their preference, and almost all subjects preferred the Galaxy Spiral IOL across all distances over a diffractive trifocal IOL. So in conclusion, the Galaxy demonstrated a better contrast sensitivity compared to a diffractive trifocal IOL. It also demonstrated a halo size closer to that of an enhanced monofocal IOL than a diffractive trifocal IOL, and all subjects, almost all subjects, preferred the Galaxy across all distances. So thank you very much. I'm really looking forward to hear now from the next speakers about the real-world usage in their patients.
Hello, I'm Başak Bostancı, and I'm very pleased to be here to present the clinical results for our multi-center study about Galaxy IOL. So let me tell you a little bit about this study. This is a post-market real-world international study. We had 10 surgeons from 10 countries all around the world, and as you may see, I'm one of them. We recruited patients who were eligible for receiving an advanced IOL optic and implanted 182 IOLs during this study. At 1 month post-op, a total of 91 patients, 182 eyes were operated, and 57 of those patients were available for this analysis. And 25 patients finished their 3 months follow-up. And our main outcome measures were visual acuity, subjective refraction, defocus curve, halo, and glare simulator results. Here is the subjective refraction of our patients in the preoperative and 3 months postoperative periods. We did a cylindrical correction where needed with Galaxy toric IOLs. So as you may see, our results were almost ametropic. Here is the binocular mean visual acuity outcomes for distance, intermediate, and near for 1 month, 3 months, uncorrected, and distance corrected. So as you may see, Galaxy and Galaxy Toric IOL showed a strong performance for all distances. And for all distances, the corrected and uncorrected binocular mean visual acuities were strictly better than 0.1 logmar. And in addition to that, we observed a stable visual acuity from 1 month on at all distances. Here you may see the cumulative outcomes for binocular visual acuity. The blue chart is uncorrected and the purple chart is distance corrected, and all results belong to 3 months. As you may see, all patients reached functional 0.2 logmar or better for distance and intermediate vision. And the majority of patients, nearly all of them, 96%, reached functional 0.2 logmar or better for near vision. So as you all know, functional 0.2 logmar is often used as a benchmark for vision studies because it represents a level of visual acuity that is sufficient for almost all daily tasks. And some regularity bodies also consider 0.2 logmar as an acceptable outcome for premium IOLs. And this is the defocus curves, binocular and monocular, for 1 month and 3 months. The blue chart is binocular and the purple chart is monocular. And as you may see, there was a peak at 0 for distance, and there was a smooth and continuous binocular defocus curve showing a visual acuity of 0.2 logmar or better across almost a 4 diopter range, starting from +1 diopter to -2.5 diopters. And there was no dip observed in intermediate vision on defocus curve that we usually see like a wave-like defocus pattern typically in trifocal lenses. And also, again here, we observed a stable defocus pattern from 1 month on. So finally, the results of glare and halo simulation. What we did during the study is at 1 month, we asked our patients to assess their halo and glare size and intensity and measured it with a simulation software. And we compared these results, the 1 month results, with published results of diffractive trifocal lenses, but this time these results belong to 3 months. So don't forget, I will try to remind you that these photopic problems tend to get better by time. So comparing 1 month results of Galaxy with 3 months results of diffractive IOLs might be a little disadvantageous for Galaxy, but actually we observed that the size and intensity were milder with Galaxy lens. So in summary, we observed an excellent binocular vision at all distances with stable results from 1 month on with Galaxy and Galaxy Toric IOL. The clinical binocular defocus curves a full range of vision extension with a smooth plateau between +0.5 diopter to -2.5 diopter and a total visual acuity range of 0.2 logmar or better across almost 4 diopters. And we observed a reduced halo and glare compared to published data on diffractive trifocal IOLs. Thank you for listening to me. And I'm really excited to hear our next speakers of a personal experience with Galaxy and Galaxy Toric IOL.
So I'll talk about my personal experience now with this, the RayOne Galaxy lens and the RayOne Galaxy Toric. The first thing I'd like to say is just to draw your attention to this study, which was done before the Galaxy Toric and Galaxy lenses were available, but it's a multi-center retrospective study of over 2,500 patients from over 115 different centers, and PROMs, which is patient-reported outcome measures, were collected and analyzed. And the results are quite surprising. And essentially what we saw, and I was one of the authors, but you can see there's a few authors there involved. The results basically show that the highest determinant of patient satisfaction is quality of vision, and actually the chance that a patient doesn't have dysphotopsia, or to put it another way, if a patient does have dysphotopsia, then that is a determinant of dissatisfaction. And that was more a cause of satisfaction to not have dysphotopsia than the patient's independence of glasses, than the patient's visual acuity, even patient's satisfaction with the surgeon and with the center. None of those things were as significant as dysphotopsia. So I want to make the point now, and I will reiterate that point, which is that I believe over many years, and in some cases even a decade or more, of using diffractive optics and full range of vision multifocal intraocular lenses, that we as surgeons have become a little bit desensitized to dysphotopsia. So we counsel our patients, if they're having a trifocal lens, we tell them they're going to get dysphotopsia. And then afterwards, if they tell us they've got dysphotopsia, we kind of think to ourselves, well, we told you we're going to get dysphotopsia. That's just part of how it all works. But we don't really envisage a scenario where they can have full range of vision without dysphotopsia, or what the significance of that is. And that's really, I think, where this lens is totally unique and is totally special. So yes, I did the first implantation in July. You can see this is the toric version of the Galaxy. And I think what's interesting really is how you observe the lens under the microscope. So in some lighting orientations, you do see the spiral for sure, but you do not see it as profoundly as you would see a diffractive pattern on, for example, a trifocal lens. So it's one of these things that when you first start implanting it, it will become apparent to you that you would naturally expect the dysphotopsia profile to be more favorable. You know, there's less on the optic that is interfering with, obstructing, obscuring light. And it's not surprising that these patients get significantly less halo and glare. OCL Vision, we have put in over 270 Galaxy lenses, and I myself will have put in around 180 to 200. So around 100 patients I personally have treated with bilateral implantations of either the Galaxy or the Galaxy Toric. And that includes all levels of ametropia and emetropia. So there was no cutoff of for that in terms of the patients that I've been selecting over the last few months. And I would say that in the centre of London, it's a kind of medical district, and the patients are very demanding. You know, they're not in general laid back, relaxed patients. In general, as you all know, patients who want full range of vision, or let's say total spectacle independence, are by nature demanding patients. But I just want to make that point that this was not a kind of predominantly cataract population of patients. Although there are some cataract patients in this group, the majority of these patients are refractive lens replacement. So they are patients who are having the surgery in order to benefit from independence of glasses, and they judge the visual quality related to how they may remember the vision to have been in themselves before they developed presbyopia. From my experience, the lens does provide a full range of vision. So when you counsel patients, you can tell them that they can expect to be fully independent of glasses. I prefer this to trifocal intraocular lenses, and now I no longer use trifocal intraocular lenses. However, there are some differences that I want to try and explain to you about how this lens performs and how you can or should counsel patients when you first start selecting them for surgery. I would say that some problems are either much reduced or totally absent, and that applies to dysphotopsia. So when I counsel patients, I tell them that they may notice halos and glare, but if they do notice halos and glare, that will be mild. And that, I think, is an accurate description of how the patients report things afterwards. So some patients actually don't complain at all of halos and glare, and the ones that will tell you they have halos and glare are generally unbothered by it. So that's something that reduces, I suppose, the counselling or the chair time preoperatively. However, the near vision, in my experience, in most patients will settle more quickly than the distance vision. So when I'm counselling patients, I still speak to them about neuroadaptation. So I still say to them that 6 to 12 weeks, you need to allow time to adjust your vision. You may not feel fully satisfied with your vision. And the thing that I found in my population of patients, in around a quarter will complain that they feel that the distance vision is a bit blurry. And that's despite having good visual acuity, not having problems with contrast. It's just a manifestation of how this lens works. And I think because they're being presented with such clear natural range of vision at close and intermediate, that the neuroadaptation element is to essentially almost filter that out so they can kind of attend to the distance vision that the lens generates. I'll acknowledge Purvi Thompson, who's our lead optometrist, because she's not only was she involved in the main study that Başak was talking about and presenting, but also subsequently we talk about patients that come back and how she feels it's performing, and she manages the optometric team who do a lot of the optometric refractions afterwards. So which patients did we select? Well, they were patients who wanted to be totally independent of glasses. For patients who don't need to be totally independent of glasses, or who don't want to be totally independent of glasses, I prefer the RayOne EMV, but I still like an extended or increased range of focus lens. But for full spectacle independence, this has become my go-to above trifocals. However, a lot of the things that you would bear in mind when you select patients for trifocal lenses do also apply with this lens. And I would advise you that when you start using the Galaxy, you should select patients in whom you would otherwise be happy to use a trifocal intraocular lens. Astigmatism needs to be treated aggressively if you like, so don't leave astigmatism untreated. The ocular surface needs to be good. So if you see that the ocular surface isn't good, you may want to treat that prior to surgery before you put these lenses in. And post-operatively, if the patient does have dry eye, if the patient does have uncorrected refractive error, and if the patient does have posterior capsular opacification, then they will be sensitive to those things, which will impact their vision, and you will need to treat those things. So I found it helpful to tell patients about that in advance, and then they're not disappointed with it afterwards. But on the whole, the fact that they don't have bothersome or significant dysphotopsia for me is essentially like a game changer. So it doesn't mean that you can just use this in everyone or forget about all the things that you are careful about when it comes to using trifocal lenses. But the fact that you don't have patients telling you that they can't, for example, drive at night is really a big change, big step change in what we can offer with this lens compared to everything that's come before. How's it changed my practice? Well, I don't use this lens above an extended range of focus lens. So if there's a reason where I feel like a patient is of the psychological type where I would not have used the trifocal lens and I would use an extended range of focus lens, I still make that decision to use an extended range of focus lens. But what I am doing actually is a little bit more lens replacement with Galaxy and a little bit less presbyopic laser vision correction. So in the past, I was put off by the dysphotopsia profile of trifocal lenses, but now that that's no longer so much of an issue, in terms of the refractive armamentarium, I'm happier to offer lens replacement now that this lens essentially, in my opinion, works more physiologically. I still tell patients not to expect the kind of vision they had when they were younger, so I think that's a good way to counsel all presbyopic patients. But it is certainly an improvement in what we've had before. And I think that the dysphotopsia point is an important point, that just because your trifocal patients aren't complaining to you about dysphotopsia, that you mustn't forget that they have that. Right? You've counseled them before. You've said to them you're going to get dysphotopsia. So many of them don't bother mentioning it afterwards because they remember the consultation. They remember that you said you're going to get halos at night. So afterwards, when they get the halos at night, they shrug their shoulders and they say, you know what, I was told I was going to get that. I'm not going to complain about it. It's bothering me, but I was told about it. And I guess that's how the lens works. And it's good that I don't need to wear glasses. But if you do patient-reported outcome measures and you ask them about that satisfaction, you should be aware that dysphotopsia that they might not complain to you about because you've already told them about it and they were expecting is still a cause of dissatisfaction. And so, interestingly, with all of the nuances of this lens of having to make sure the ocular surface is good and treating any refractive error and astigmatism and yagging capsular opacification, throughout that whole process, the patients are still satisfied. So they might say to you, my distance of vision is a bit blurry, or, can you help me with this? Can you help me with that? But the overall satisfaction, I believe, is higher despite those things. And they can tolerate those things better. And that includes even, uncorrected visual acuity that isn't as good as you may have been hoping in a small minority of patients that may come out a bit more minus or a bit more plus than you'd expected. Despite that, they're not as dissatisfied because they don't have dysphotopsia bolted on top of that, right? If you do a trifocal patient and they come out -1, not only is everything blurry, but they also have halos and glare at night. So here you're dealing, if you like, with less problems, but those problems still need to be dealt with afterwards. And there is still a kind of aftercare requirement for this lens, which you should be aware of, and also aware of in terms of how you select patients and how you start using this lens in your practice. And we hope to be able to provide you with more RayPro data collection. So it's something that is actively happening in several practices. This only became available for kind of widespread commercial use in January, so this is very early, if you like. And that's that's data and that's information that we hope to be able to provide, so we could do a like-for-like, real-world, clinical PROMS, RayPro outcome data collection to show you the trifocal satisfaction versus the RayOne Galaxy. If you're interested in RayPro, I believe it's free for users of the Rayner lens. Whoever your local Rayner rep or distributor should be able to help set you up with it. In our experience, Rayner have provided a lot of support with this because they recognize how important this kind of information and data is for surgeons and practices to be able to introduce new technology, see how it's working, and then make decisions on what you think is best for your patients. If you are interested in more information on top of what's being presented in this webinar, then there's a lot of stuff on peer-to-peer, which Rayner have put together, and the Rayner YouTube channel. I've put my Instagram handle down here, so if any of you want to connect with me there and send me messages or follow me, I'm very happy to interact there as well in future.
So let me start asking you, Allon, about the very first one that has been asked by many of our colleagues. What about mixing and matching the Galaxy with the RayOne EMV? Do you see any need or situations where that could be advisable? Are you doing it? You are not doing it? Give us some hints about that.
Yeah, so I personally don't have any experience of mixing and matching with this lens. In fact, as it happens, I've not even used it unilaterally, which I think would be a perfectly reasonable thing to do. That with all of these lenses, there is a summation effect, which means that however the lens is working optically in one eye, it will be enhanced by having the same mechanism of action in the other eye. And I guess, the introduction to that is when you start using unilateral implantations for unilateral cataract. But it's just so happens, maybe because, as I said, the majority of the patients I've operated on are lens replacement patients who would require surgery in both eyes, that I would use it in both eyes. I wasn't a mix and matcher for trifocals either, even though I know that there's people that use EMV in one eye and trifocal in the other, and they say the results are great. And you always come across patients where you may explant lens in one eye and they say, everything's great now, even though they have the same lens in the other eye. So I do understand that in some patients, there is likely to be a place for it, but I myself haven't kind of figured out in which patient that would most apply. And so for the reasons I've just given, is I basically put it in both eyes.
Thank you very much, Allon. Questions for the other panelists. Raphael, how are you positioning the Galaxy in your daily practice today? I mean, are you still implanting other trifocal IOLs? Are you addressing more patients to the Galaxy because of the lower amount of dysphotopsia that it uses compared to the other presbyopic retinal IOL? Tell us something more about that.
Yeah, for me, basically, I don't have as much experience probably as all of you. However, we started in last September, October, slowly beginning planting the Galaxy IOL, and our use case basically is now the refractive lens exchange, and also cataract patients with a healthy cornea, but also interestingly, as Allon Barsam also said, we used it already in higher hyperopes, also high myopes. So actually it's at the moment the go-to presbyopia lens, because I see myself and my team, my optometrists, asking ourselves, why would we go back to a trifocal lens when we know now what we see from the Galaxy lens? Why should we take something what produces, for example, more dysphotopsia? So I'm very, let's say, careful still, because somehow maybe it's too good to be true, but that's what you were telling us, the colleagues here, how it develops. This is what I'm seeing here. And I'm not doing more than than before, but in a lot of high demanding also cataract patients, what we also have in Munich, Germany, as Alan said, probably in London, that they have already early disturbances of the human lens getting cloudy. They're still working, they're still in the business. So I think that's the use case there, yeah.
Başak, what about you? How are you positioning the Galaxy in your portfolio of IOLs?
Well, I have always been very selective for trifocal lenses. I wasn't implanting more than 10% of my cataract population, although my population is very demanding because I'm working only private. But with Galaxy, I'm not implanting trifocals anymore. It is my new presbyopia correction lens. But I figured that I am allowing myself to implant more because I think it is more, you don't have to be selective for the alpha angle, let's say. I was very selective for post-refractive cases. Now I am implanting Galaxy in post-refractive cases. And in fact, we sent our abstract to ESCRS about the post-refractive cases, and our results are very satisfying. So for any patient who is deserving full spectacle freedom and whose cornea is good, whose retina is good, I'm not talking about pathologies, of course. I'm not implanting trifocals anymore. Galaxy is my lens, and I am allowing myself to implant in more patients that I used to do with trifocals.
There are a few questions from the audience related to the comparison with competing technologies like other trifocals and non-diffractive increased range of focus IOLs. I don't know if you have a direct experience. I think that at this point it's not worth comparing this technology with others because the numbers and the follow-up period that we have is not long enough to really make statements. I think this is, I think the Galaxy is a very nice lens to be implemented in our portfolio of weapons to provide patients with a full range of vision, spectacle independence after lens replacement, either for cataract or refractive. But sophisticating if it is better than others, I think is still relatively early. What the other panelists are thinking about it?
I think comparing a refractive optic with a diffractive optic is comparing apples with some other kind of fruit, because diffraction, you start by losing. You are just diffracting light into 3, and then you start by asking the patient to read with 60% of the light that is available. But with refractive technology, you are allowing the person to see with 100% of the light for far, for intermediate, and for distance. And for me, the most spectacular thing about this lens is I always know when I am, so we don't have optometry system in Turkey, so we are doing our post-op measurements about the visual acuity, and I allow my patient to hold the reading shell and, hold it wherever he is comfortable with and start reading. With Galaxy, they don't know where to hold because they can see at all points, but diffracted trifocal patients always know where to hold it because 5 centimeters ahead, 5 centimeters to the head, it's not easy for them to see. But Galaxy patients can see at all points, so it's continuous. I really like the continuous ability to see at all points from near to far.
Yeah, from my point of view, I think that the non-diffractive technologies are taking more and more of the space in presbyopia correcting IOLs. Just because of the lower amount of dysphotopsia they provide at the end of the day. So I really think that, I really consider the Galaxy as the really first full range of focus, purely refractive technology that is available today. And in my own practice, the lens took a huge space for providing patients a full range of vision when they really target at, not being spectacle independent at any distance. The comparison with other technologies as the PureSee or the Synergy as requested by the audience, I think it's still early to make. That's the point that I'm making. we probably need more numbers and a wider experience to really assess if there is still room for other technologies or if the Galaxy can be the one-size-fits-all lens that it looks like maybe when trying to address full range of vision correction with presbyopia IOL implants. We have some questions related to retinal status and the implantation of the Galaxy. So those cases where you have a little bit of, retinal pigment epithelium dystrophy or early stages of, retinal problems, would you be confident in implanting a Galaxy? And the question goes to the three of you, or are you still conservative?
Maybe I start from my point of view. In my use case, when we use presbyopia correcting lenses, it actually, if there's early changes on the retina or maybe also on the cornea, with the epithelium, endothelium. I only perform it on healthy eyes, actually.
I'm the same. I was the same with trifocals. I'm the same with the RayOne Galaxy.
The same. No pathology. It should be a healthy eye.
I think the same, although I am more adventurous with the Galaxy compared to trifocal IOLs. In other words, I as well as for post-refractive surgery eyes, where I started implanting the Galaxy with satisfactory results, I think the lens is very forgiving in terms of quality of vision and in terms of contrast sensitivity. So for all the cases where there is a little bit of challenge in implanting a trifocal, but you are really at that point to say yes or no, well, I think that these cases may be a yes in future. Time will tell. There is a lot of interest in knowing what are we targeting in terms of refractive outcome. Are we targeting the first plus, the first minus, whatever is close to plano? What is your indication, Başak?
I am going for the first plus.
Allon?
Same.
Raphael?
Yeah, same.
Yeah. There is another question going along with this one. Is anybody doing some sort of mini monovision with the Galaxy as to further expand the range of vision?
You just don't need to. It's just so good for near. Even though the ad in the IOL plane is 3 diopters, it doesn't perform like a 3 diopter ad intraocular lens, and I think that's because of what Başak said with the natural range of vision. And I think the reading element of the lens is also kind of one of the things that's quite positively surprising with this, because when we test patients in the clinic, sometimes we either force them to look at a certain distance or we allow them to kind of find the range. And the neuroadaptation element with trifocal lenses was often exactly that they would have to take some time to get used to where the sweet spot was for reading vision. And this lens doesn't function in that way with a sweet spot, which is really useful because where someone wants to hold their phone is not the same place as where someone might be on their laptop or when they're on the go and they're approaching something that they want to read. So they have vision at all those distances. And we also found the reading speed to be quicker with the Galaxy. So it really does give a better quality of vision for reading in elements that we don't normally test for. But when you see the patients afterwards, that's something that you become aware of. So you don't need to do more than what you would otherwise expect to do in order for them to be satisfied and happy with their reading. The exception to that is if you end up with a refractive surprise and they end up with hyperopic refractive surprise, that maybe will skew their reading. But of the kind of 200 that I've put in and the 100 patients, I think I have one patient where that applies, which is what you'd expect in such a large cohort of patients. So it's not really a concern that you have to do more to give them better reading vision. The reading vision is good enough, and you can counsel them that they will be independent of glasses for reading when using this lens.
So one of the two take-home messages is that with the Galaxy as well, you must be accurate, you must be right on target to get the best performances from the IOL. So according to this, do you have any preferences as regards your preferred formula to calculate the IOL? And what is the minimum astigmatism that you will correct or you will leave behind without correcting? So what is the threshold for you to decide whether or not to correct astigmatism with the Galaxy?
For myopes, I go between Barrett and Hages. For hyperops, I go between Kane and Hages. And for astigmatism, if it's an against the rule astigmatism, I correct everything more than 0.5 diopters. If it's with the rule astigmatism, I correct after 1 diopter of astigmatism. Usually they want me to correct even after 0.75 for with the rule, but what I do in my clinic is against the rule 0.5, with the rule 1 diopter.
So basically with formulas, I look at actually the Barrett formula. Also, many times I use the ESCRS formula basis to see a lot of formulas parallel to each other, as well as the Rayner with Pearl DGS and I ray trace. And I compare basically all of them to see where it goes. And for astigmatism, it's from 1 diopter on. I do it with toric IOL. Below that, most of it, of the astigmatism is corrected with the limbal relaxing incision using the femtosecond laser. In most of the cases, with refractive lens exchange, we have femtosecond laser assisted surgeries, and then we use that.
So we use the Hill RBF. I mean, we have the iStar as our biometer, so the Hill RBF is incorporated into that. But we will also use the ray trace calculator, which has Pearl DGS incorporated into it, and then I take both into account. But the ray trace calculator has become very accurate on account of updates that have been made to it, and it's very user friendly for anyone that hasn't used it recently. It really works nicely. So it's another nice innovation from Rayner. For astigmatism, I will not leave more than 0.5 diopters on the cornea for against the rule. So under 0.5 diopters for with the rule astigmatism, then I would tolerate maybe 0.65. But I'm using the Galaxy toric much more frequently than just the Galaxy without toric, because I just want to make sure I eliminate astigmatism. Again, as we get more comfortable and we have more months and more years that go by, and then maybe I can be a bit more relaxed about it. But for the time being, I'm just trying to do everything in our kind of technological armamentarium to maximize the outcome for these patients.
Another hot topic. We know that the Galaxy has this central part, 1.1 to 3.2 millimeters spiral optics. So one of the questions that arises frequently in this chat is how sensitive is the Galaxy to pupil size, and if anybody of you has any restriction or indications as regards pupil size, either to implant or not to implant the Galaxy for extremes.
I didn't have any extreme cases, but I am in accordance with Allon, because I think it is less pupil dependent compared to many diffractive optics with rings. But I didn't have much extremes.
Patients with tamsulosin or finasteride or something like that, where they have no dilating pupil really left. I don't use these lenses. I don't use diffractive lenses. But with large pupils, I didn't have any issues yet.
Yeah, I've not excluded any patients on account of pupil size, and I've used it in patients that have more than 7 millimeter pupils. I suppose if someone had pupil size of like under 1.5 and it just didn't enlarge for some reason, like they were maybe on pilocarpine or something like that, then you might not expect the lens to function in the same way. But those patients have so much pseudo accommodation that they'd probably be able to read anyway. So I haven't excluded anyone. I mean, I haven't come across anyone with tiny pupil, but I haven't excluded anyone on account of large pupil, no.
Let's start with some tough questions. Would you recommend this lens to like professional night drivers, taxi drivers, truck drivers, and so? Or let me rephrase it. Would you recommend it better or more than a trifocal, traditional trifocal? Allon, you can start.
So I that's one of the big advantages of this, is that you don't get specific nighttime vision problems. So yes, I would have no problems using this in a professional night driver. There were many that used to put trifocals in such patients, but I didn't. So, I didn't used to use trifocals in such patients, but would use this lens in those circumstances if that was, if patients required or demanded full range of vision or total spectacle independence.
I had 2 patients that actually not professional drivers, but they actually by themselves told me that they're
surprised how good their nighttime vision is, because we have short days in Germany over December and November, and they actually, experience a lot of dark situations around the time of implantation. And they actually give me confidence to do that.
I don't necessarily recommend a lens to a driver. If he wants clear vision for far, I will explain that monofocal will give him a clearer distant vision. But if he requires also reading at the same time, and if he asks for a premium or presbyopic lens correction, rather than putting a diffractive lens, I will go for a Galaxy.
The three of you are all very experienced with the RayOne, regardless to the optics, the RayOne platform. What about rotational stability of the lens when toric is implanted to attempt a perfect vision? Any comments? Is it rotationally stable? Do you see that it is difficult to align? Do you see any late rotation of the lens?
The Rayner lenses, they exert more compressive force at the equator than many other lenses, so they just don't move at all. I've used thousands of Rayner toric lenses, which is essentially the same platform. I've only had one patient that I can remember where there was a rotational issue with them. I think providing it put in the right place at the time of surgery, you mark the cornea well. You just don't have to worry about that. That's a huge benefit of this platform.
Yeah, same here. I didn't do any re-rotation. I didn't need to.
I have one last question for the three of you with a very quick answer from a clinical standpoint, and I give you my answer first. Do you have any real complaining patients in the series of lenses that you have implanted? My answer is no for now. So patients are quite happy, but most interesting, I do not have any one of them complaining as regards either quality of vision or night vision. They may report some halos around night, the lights at night, but what I find it very interesting is that they do not complain at all. What is your feeling? What is your experience?
So I always have complaining patients. I wish I didn't. But they definitely, I really do feel that they complain less than patients with trifocals used to complain. And they complain about different things. And it's a minority. The majority of patients do not complain. They're really happy. You do the surgery, don't see them again, and there's no problems. But if you don't achieve target, if they have some capsular opacification, if the ocular surface isn't good, they're going to perceive blurry vision. Normally it's blurry distance vision, and you'll need to manage that. But it's less of a kind of wholehearted emotional complaint than you used to get with a trifocal lens where they can't drive at night, for example. So you're swapping, one complaint for another, and the complaint that you're accepting with this lens is one that bothers patients less. That's my experience.
In my case, because I was a part of the study, I was letting the patient always almost pushing the patients to complain. I was asking them questions. How is your nighttime vision? How is your reading speed? I was asking questions like that. So I let them to complain. I only had, trust me, one patient who complained about anything. And she was, I think she wanted to, she didn't want to wait for the neural adaptation, and she wanted things to be very quick. And she complained about far vision. She was able to see 20/20, but she said it wasn't very, very clear. And, it was in the first month of the surgery. So after things settled down, she got better, but she complained about the far. But she never complained about the intermediate and near. She started saying my near is perfect, my intermediate is perfect, but by far isn't not good. She always started complaining like that, but after 1 month, she got better.
We do have complaining patients, and I think we will keep on having them, but it's also not the typical, for me, with diffractive lenses, it was always, in the first weeks, two post-operative consultations, they told me about the halos. Now I know what you were talking about. I see them, even if I didn't ask them. I don't have that, and it's similar to Başak, what she said that now we hear there's less halo, and we ask the patient, do you have any halo issues at night and all that? And I don't get this as much. And a lot less. And the other reasons is most of the time, I think, ocular surface actually that limits a lot of fast rehabilitation as well and has to be treated. But that is no real complaints. Yeah.
Thank you very much. Well, I think it's time to wrap up now. I really like to thank all the panelists and for their excellent presentations. I'd like to thank the audience. Thank you, Rayner, for providing us this space, and let's see what happens in future with this exciting technology.